Hey Corsicana, LVN program, class of 2020. I hope everybody's doing good, sitting at home. Nobody's going anywhere and you're just trying to bunker down and study and be in school. We really have benefit that we are in school right now and we can really contain ourselves to our homes. Most of us can. So my doggy, Jax, is very happy I'm home. He's ecstatic, but he doesn't like to be held very much. That's the only thing I don't like about this. I love this dog, don't get me wrong. But I had a dog before this, I had a little poodle, and he was so lovable, like he would just want me to hold him. Jax has some anxiety issues, so he doesn't want me to he doesn't want me to hold him very much. So, but this is Jax, and he's cute. Hey Jax, look at the screen. Look at the screen, Jax. Okay, see what I mean? He wants down. So this is my 15-pound anxiety-stricken Yorkie, who is extremely, look at his eyes. It looks like reminds me of a rabbit. He's extremely happy that I'm home. He doesn't know what's going on here, but he's glad I'm home because he has major anxiety when I leave for work. Okay, as promised, I told you I was going to video lecture and I'm going to review the sections that we covered last time in lecture, which had to do with fetal monitoring. So if you will open Canvas, open it up. If you need to pause the video right now to go ahead and open Canvas up, follow along with me on these PowerPoints because those are posted on Canvas. So you should be able to follow along easily with that. Get your textbook, turn to page 141, have that ready so you can kind of look at your textbook as we're going along. And have you a notepad and a pen to take notes on if you need to take notes during the lecture, whatever's the most helpful for you. And the benefit of this is you can watch this video again if you want to, and that will help you, like some of this maybe soak in more. So the reason I decided to review this part again is because the fetal monitoring is probably the hardest part to understand in obstetrics. It's also, in my opinion, the most fun. It's the most fun part to learn. It's the most fun part when you get into practice and you're able to use it in practice. It's the scariest part for sure, but once you know what you're doing in that area, it is a lot of fun, okay? So let's just review. Go to the PowerPoint that's entitled Changes in the Baseline of the Fetal Heart Rate, okay? So let me just take this out of here so I can show you what this particular PowerPoint will look like, okay? So this one looks like that right there. Do you see that? Okay, so if you can get on that PowerPoint in Canvas, you'll be able to follow along with me. On page 141 in your book, it shows you a fetal heart rate tracing, okay? So this is what I'm looking at right here. So just briefly, I wanna talk about the fetal heart rate tracing and a couple of things. So this is the fetal heart rate tracing. So you have on the top, you have the fetal heart rate, and on the bottom, you have your contractions. Okay, sometimes there may not be any contractions, so this will just be flat. Remember I told you that it's a button on the back of the monitor for the contractions. So it really makes a difference if this is an overweight, obese patient or a very thin, skinny patient. The contractions will be larger because it's just a button. It's not really telling us how strong they are, okay? So we'll cover again on contractions here in a minute, but let's look at that. We wanna see the contractions because you really need to know if you see contractions, what the baby is doing in response to contractions, because contractions, remember, are a stress. They're a stressor on the baby, okay? So remember there's numbers here that you can see, and what you do is you go up to the fetal heart rate tracing. You see it's very squiggly, and what is that called? Variability. When it's squiggly, it's called the variability. How much it fluctuates from the baseline is a better way to term it other than squiggly, but it's easy to understand that. So how much it fluctuates from the baseline is called the variability. So the variability could be absent. That means it's not going from baseline at all. And that's called absent variability. It would be a very flat line, okay? And then you have minimal variability. And if you look in your book, it defines how many beats per minute it fluctuates from the baseline, if it's minimal, if it's moderate, or if it's marked. And sometimes marked can mean the baby's starting to get into a little bit of distress. So you really just want it moderate. The babies will have periods of absent variability and periods of minimal variability could be induced from medications such as what? Stadol or Demerol or any kind of narcotic that could, or fentanyl. Those are drugs that are used in labor and delivery, and so that can cause the variability to decrease, but it shouldn't stay decreased. It should just be intermittent, okay? So we do want to have periods of times when we see moderate variability. Some people call it average variability, and that's okay. It's just the same, means the same thing. So it's fluctuating from the baseline, good. I do not expect you to memorize how many beats per minute it fluctuates from the baseline for each one of those terms, like for absent, minimal, moderate, or marked. You don't have to learn that. I just want you to know the difference. I just want you to know the terms. You just need to know that variability, what variability is, and that you can define it as absent, minimal, moderate, or marked. That's all I want you to know about variability, okay? And then it can mean that there's problems with the central nervous system. It's central nervous system depression is really what it is when you're looking at variability. So I hope that makes sense on the variability, because variability is one of the hardest things to understand on fetal heart rate tracing. So I hope that helps. Okay, so you can tell just by looking at this strip right here that this is pretty good variability, right? It's fluctuating really good. I like that. Okay, I like this strip. This strip's pretty good. So we only look at 10-minute strips. That's pretty much what we look at. You just don't want to look at just one little section. You want to look at a whole 10 minutes, and then you describe what you see. So what I look at is I look for what's called periodic changes. All that means is anything that changes from the baseline is called a periodic change. It could be an acceleration. It's accelerating from that baseline. It could be a deceleration. It's decelling. Okay, so the decelerations are not the same thing as the variability. The variability is the overall fluctuations from the baseline of the fetal heart rate. Okay, so if it was 120, remember I told you if you could draw an imaginary line right through the center of the fetal heart rate tracing, that's your average fetal heart rate. And remember, it should be between 110 and 160, okay? As the baby gets older, typically the heart rates tend to decrease on the fetuses, okay? So if we look at this tracing, we see it's a 10-minute strip. We see that it's good variability. It looks like, I have to look here, but it looks like it is. These numbers are tiny, very tiny. It looks like it is in the 120s, if I'm seeing it correctly. And it is having good variability, I'd say moderate variability. And there are periodic changes. That means there are accelerations. Okay, so I'll give you an example. Remember, each little box counts for 10, okay? So if you look, it can count for 10 seconds this way. Each little box count for 10 seconds this way, or if you're going up and down, it's 10, meaning the heart rate 10 beats. Okay, so so you count the boxes. So let's say your fetal heart rate is 120s average, and you're counting how many boxes would be, like here's an acceleration right here. Do you see that? Okay, so if I look at that and I count the boxes above, it's going up 2 boxes. If you look closely at your paper, you'll see it's going up 2 boxes. So that would be 20 beats above the baseline. And it's definitely lasting at least 15 seconds, because that acceleration, I can count 1, 2, 3, 4, 5, 6, 7, 8. I can count 9 boxes. So that one lasted 90 seconds. So it only has to last 15 seconds. We're talking 15 by 15, and we need 2 of those. So that means 15 seconds long, the acceleration should last, and it should be 15 beats above the baseline. So we need 2 of those in a 10-minute window to be able to call the tracing reactive, okay? So we can do a non-stress test, which is where we put them on the monitor. We give her a button to push so we can see if the baby moves, what the heart rate does in response to movement. And then if we see those 2 accelerations in 10 minutes, we say she has a reactive non-stress test. So we feel like she's in good shape. That's the way we determine that. So the other thing could be decelerations that can occur with the periodic changes. Okay, so I'm going over this tracing. So you can see the first thing on there is acceleration. Accelerations, like I said, 15 by 15. 2 of those in a 10-minute window is what we're looking for. If we only saw 1, we would just keep monitoring. Sometimes we give her orange juice or something to kind of help. The sugar will kind of help make the baby move more and will give us more chances of getting those accelerations. Okay, now we're going to talk about the decelerations. So the early decelerations. So the early decelerations mirror the contractions right along with the contraction. Just dips down right along with the contraction. That is indicative of head compression. Early decelerations are indicative of head compression. That means that you either have someone who's progressing quickly and you need to check the cervix to see if she's dilating fast, or it could be that she has CPD, which is cephalopelvic disproportion, and in that case, maybe the cervix is not dilating because the baby's head is too big to fit through the pelvis. You will see early decelerations. What's happening is the baby's head is pushing against the cervix and causing a vagal response, so it dips that heart rate down. But it's by the time the contraction's over, that deceleration has recovered. So that's how you know the baby's not in severe distress, but it's just an indicator that there's something causing head compression, okay? So I don't know, sorry, my nose is itching, y'all. I don't know what's going on. I don't know what would help you remember that earlies and head compression, but I do have a, like an acronym I'd like to send you. I'll put it on Canvas, is what I'll do. It's called VEAL CHOP. And it helps you remember what the decelerations are and what the interventions are. So I will try to get that posted for you too. Then you have late decelerations. So late decelerations look like the early decelerations. They look just like them. The difference is they're late. They're after the contraction's over. They're still dipping down. That's a sign of distress. Because remember I told you a contraction is stress on the baby. Well, if the stress is gone and the heart rate is still down, then you have a baby that doesn't have enough oxygen reserve. So the baby's not recovering. So that is a bad, ominous sign. Ominous means bad. It's a bad sign. That means that we've got to do some interventions, okay? So what do? Well, we can turn her on her side, take that pressure off that vagus nerve. We can give her IV fluids to increase volume. We can turn her Pitocin off because we got to do something to take that stress away for right now because we're having late deceleration. So if we keep having this uteral placental insufficiency, which means lack of oxygen going to the placenta and to the uterus, then the baby's going to have problems with oxygen, which could end up having deprivation and brain damage. So we don't want to let those late decelerations continue. I hope that makes sense. Okay, so we would give her oxygen also by face mask with the bag, the reservoir bag, because we want to get as close to 100% oxygen as we can get. So that's what we would do, okay? And we usually set it about 8 liters when we do put her on the oxygen. The other thing, we always want to call the physician if we're seeing repetitive late decelerations. And then sometimes if they're just continuing, you've done all those actions, you've got to go ahead and start prepping for a C-section because your goal is to go ahead and get the baby here if it's not getting any better, okay? Then we have variable decelerations. They're called variable decelerations. They are shaped like a U, a V, or a W. Now this is one. Now with the late decelerations, it doesn't matter how far down it goes. The fact that it's still not recovering when the stress of the contraction is gone makes it bad, automatically makes it really bad and ominous. With a variable deceleration, it does matter how far down it drops because if you'll remember from lecture, that indicates cord compression, some type of cord compression whenever you see a variable deceleration. So it's like the cord could be wrapped around the neck, which is called a nuchal cord. So in that case, the contraction's getting stronger and stronger, the cord's getting tighter and tighter and tighter, and the deceleration is getting deeper and deeper and deeper because it's cutting off the circulation, just like if you were being choked or somebody was being choked. The same concept. It could be shaped like a U or it could be shaped like a W, but it does matter how far that one dips down. If it dips down real deep, then it's being cut off a whole lot more than if it just dips down a little bit. So your interventions are different if they're just a little bit there or if they're deep variable decelerations. If they're deep variable decelerations, then you really do have to intervene. So let me see if I can find this in the book here. I think there is a picture. There is a picture on page 142 of your variable decelerations. These are not bad variable decelerations. Let me see if I can find here, sorry. You have mild, moderate, and severe. So it tells you that the mild variable decelerations are less than 30 seconds long and less than 80 beats per minute below the baseline. So it's not dipping more than 80 beats per minute below the baseline, okay? These definitions are on page 142, okay? You don't have to know specifically what they are. I don't expect you to remember the numbers on these, but you can look at a strip and you can see that these aren't bad variable decelerations on page 142. I would call those, if I can count the boxes of how far it's dipping. It's lasting about not even quite 20 seconds at the widest part, and it's dipping down 10, 20, 30, 40, about 50 beats below the baseline. And then if you look at that strip too, you can see that it does not have very good variability in that certain 10 minute strip. So you've got the mild, moderate, and severe. So if you see severe variable decelerations, those are bad. That means the cord is somehow being compressed down like more than 70 beats per minute below the baseline for more than 60 seconds. And I've seen them really deeper than that. I've seen them dip down to like 20 beats per minute. It's pretty scary when you hear that happening you can hear the fetal heart rate going. So that can be pretty scary. I do have pictures in my slides of deeper variable decelerations than that. So this could be the cord has prolapsed, and there's different kinds of cord prolapse. You could see a cord prolapse that is occult. That means you don't see the cord hanging out. You just have these variable decelerations going on. So you're just assuming there might be a cord prolapse in there, but you don't see it. Or you can have a visible one. You actually see the cord prolapse out. That's the one where you gotta hold the pressure off the cord, off the baby's head, and you're gonna be riding to the OR as you hold that pressure off the baby's head. Because this baby can be in a lot of trouble if they're having their heart rate drop that low. So you wanna get them into a different position if you're having those deep variables. Like you might put them in knee chest position, that takes pressure off. You might put them in Trendelenburg position. You might give her oxygen. I mean, it's really kind of, there's a lot of controversy on whether oxygen really helps when there's a variable deceleration, because if someone was being choked, oxygen would help you. But we typically do go ahead and put oxygen on as a precautionary measure. We would put her in those two different positions. We might actually have to do an amnio infusion where we put that IUPC in, that catheter that goes in there and sits next to the, sits inside the uterus. We can put fluid through that. And sometimes that helps float the cord, because the cord is, for whatever reason, it's being compressed. Maybe there's not any fluid left, and it's been so long there's not enough fluid that it's compressing the cord. So we got to get some fluid in there. So there's some different things. Sometimes the only cure, if it's bad enough, is get her in the OR and get the baby out. That's the cure. So getting her changing position is really the biggest thing with the variable decelerations. It's non-reassuring, obviously. These are non-reassuring, okay? So that's pretty much it. Be sure you look at page 141, box 6.3 where it has classifications and interpretations of fetal heart rate and uterine activity. Let me look here at that. I'm sorry, that's 141. It tells you like the, right here. So it tells you the normal baseline is 110 to 140, sorry, 110 to 160. And then it goes into the different categories like absent variability, and you don't have to memorize. I don't want you to memorize this. I just want you to read this, okay? Especially where it says non-reassuring patterns over here on this part here. Be sure you read this where it says tachycardia, because sometimes tachycardia can be an issue if it's greater than 160 and it stays there. Bradycardia is less than 110. That happens sometimes. Decreased or absent variability is can be an ominous sign. Late decelerations are always an ominous sign. Variable decelerations, if they're severe, are ominous. And then you've got abnormal uterine activity. So we talked about the contractions, and they need to have a resting time and all that. So go back and review that. And we talked about remember we talked about how far apart they are. So they have to be at least 2 minutes apart. So 120 seconds from the beginning of one contraction to the beginning of the next. And remember we talked about the resting period needs to be at least 60 seconds in between each contraction. And the contraction should never last more than 90 seconds. So you count those little boxes because each one is 10 seconds. Okay, so we went over that in class, and hopefully you kind of got that part, the contractions. So the next slide says reassuring fetal heart rate and uterine activity. So we said this already, but the 110 to 160 with variability present, accelerations that are there, that hopefully there's 2 of those, 15 by 15 in 10 minutes. And then the contraction frequencies are 2 minutes or greater, durations 90 seconds or less for each contraction, and relaxation intervals at least 60 seconds. Okay, the next slide says non-reassuring fetal heart rate is what we just went over, the tachycardia, bradycardia, absent or decreased variability, late decelerations or severe variable decelerations, and absence of variability. Okay. Then the next slide is just a picture of someone on a monitor. The next slide says variability, and we just went over variability, so I hope you got an understanding of that. The next slide shows what early decelerations look like, and it's got actual arrows going down. Okay, so here's the early decelerations. See, they're right with the contraction. That's how you know they're early. Okay, so remember what we said that was? Do you remember? That's head compression. So that would mean go check her, see if her cervix has changed. If she's not progressing, it could mean that she has CPD. This one is late decelerations. Do you see the contractions here? Okay. Do you see that the deceleration is happening after the contraction's over? See, we're in the resting period here, and the late deceleration's happening. It could start right in the middle here and just still be going on like right here when the contraction's over. It doesn't matter where it starts. If it's still happening after the contraction's over, that's called a late deceleration. That's not good. Turn them on their left side. Give them oxygen. Turn the Pitocin off. Call the physician. Give them fluids. Those are the things you would do, interventions that you would do for late decelerations. The next one, tracing, is just a picture. We'll skip over that one. That one's kind of blurry. So, but that one's actually a good looking tracing. You can look at it and you can see there's no contractions, but there's good variability. So we got moderate variability going on there. This next slide is just another picture, and it shows early decelerations. You can see they're mirroring the contraction. They're right with them. So what does that mean? That means head compression. Okay? Doesn't mean the baby's in distress. It just means there's head compression. The next slide's another picture. This one is showing the contractions. You remember I told you that each box is 10 seconds. So you remember you count from the beginning of one contraction to the beginning of the next by 10-second boxes. That's how you determine how far apart they are. and you take a 10-minute strip. So some of these are closer together than others. So you might come up with 1.5 to 3 minutes or whatever. That's what you would chart for that 10-minute strip. What do you think these are? Yep, they're variable decelerations, because see how they're shaped? They're pretty severe variables. They're pretty severe. They're lasting a good while there, and they are dipped down really deep. So we got to worry a lot more about those. Remember, the late decelerations, it does not matter how far that one drops down. The fact that it's not recovered after contraction is over is the problem. But with the variable deceleration, it does matter. It matters how far down it goes. So this is deep. You would, what do? What's your actions? Change their position. Put them in Trendelenburg. Put them in knee chest position. Give them oxygen. You might stop the Pitocin. You might have to hold the cord. Look for a prolapse cord. You might have to give an amnio infusion. Okay, but the main thing there is you got to change the position. Now these are extremely severe variable decelerations. Look at that. That is real bad. And notice the variability is bad too. So it looks like the variability, see how fine the line is? It looks like the fluctuations from the baseline, it's so minimal that this baby's in a lot of trouble. This baby's in a lot of trouble. These are deep, severe variable decelerations. There is a cord probably wrapped around the baby's neck in this position, in this situation. This baby needs to be delivered stat. If you don't get this baby delivered stat, this baby's gonna be in big trouble and probably end up with brain damage. So have to take immediate action or you're gonna end up with no heart rate at all, okay? All right, so then you have what's called a prolonged deceleration. So if your baseline drops like that and it keeps going for a minute or longer, it's called a prolonged deceleration. Scary situation to be in. You are like running around the room, you're getting your Foley catheter together, you're shave prepping, well, they don't shave anymore, they clip now, but you would be getting everything ready, the IV fluids, calling surgery, making sure that they've got all their blood work done, consent signed. There's just a lot to do, and you don't know if it's gonna come back up or not. All you know is it's dipped down to like 40 beats per minute and your baby's in trouble. Okay, we talked about labor support, about how she could be in the upright position. Usually she's actually sitting in a semi-Fowler position because hospital beds can be put in semi-Fowler position. That's pretty much what they do. There's more lax places like birthing centers might let them squat during delivery or walk around more and things like that. Be sure and go back and review like how often you can walk around, how often monitoring is for someone without any risk factors and then someone with risk factors, okay? Teaching, there's a lot of teaching. There's a teaching, let me go here and look for you. I think there's a teaching in your book on, let's see, on page 149, it talks about teaching. So be sure you read that teaching section, okay? Always include the partner, support and encouragement. It takes a lot of support and encouragement for this part of the labor process. Remember, she has to avoid pushing until she's completely dilated because that can cause a laceration. So we want to make sure we don't have her push. So she could have a real strong urge to push, but we don't want her to, okay? All right, so now we're gonna get into the stages of labor. So this is important. That's the name of the slide. It's called 4 Stages of Labor. Okay, hopefully you're able to follow along with me pretty good here with the slides. And the other slide right before this was called Teaching. This one's called 4 Stages of Labor, okay? So the first stage to dilation, that's the first stage is the onset of labor to the full 10 centimeters, okay? So the first stage is also subdivided into phases. So there's latent, active, and transition, okay? So that's the first stage. So it's 0, the onset of labor, to 10 centimeters dilated, and it's subdivided into the latent phase, the active phase, and transition phase. The second stage is expulsion of the baby. That requires full cervical dilation, obviously, for the birth of the infant. The third stage is the placental stage. That's when the placenta is delivered. The birth of the infant to the birth of the placenta, that is considered the third stage. And then the fourth stage is the immediate post-birth recovery period. That's 1 to 4 hours post-birth, okay? So on page, I have page 155 to 156. Let me look and see if that's right here. Let's see. Yes. So you're going to want to really read over pages 155 to 156, the labor process and nursing interventions, because it goes through the latent phase, how it lasts 4 to 6 hours, and she's 1 to 4 centimeters. Then the active phase is 2 to 6 hours, and she's 4 to 7 centimeters. And the transition phase is 30 minutes to 2 hours, and she's 7 to 10 centimeters at that point. It talks about the contractions, how they are. They start out at like every 5 minutes in the latent phase. They're 2 to 5 minutes apart in the active phase, and they're every 2 to 3 minutes in the transition phase. So be sure you read over all of that, and you could read about how the mother behaves during these periods of time. You'll see a big, huge change in her behavior in the transition phase. She gets extremely irritable. She starts to reject people that are helping her. She really turns inward during this point. And those of you that have had children and babies, if you were awake and you during this time, you know what I'm talking about. You totally turn inward. You don't really see or hear anybody around you anymore. So while I'm yelling at these patients to don't push or do push, sometimes we're having them push at this point, they sometimes won't hear me, and you've got to reel them back in to focus on what you're saying, because they're very, very turned inward with all the pain and pressure that they're feeling. They lose control a lot of times. Now, they do get a lot of epidurals these days, so that does make a difference. So people that have epidurals don't experience the same type of extreme pressure and pain like people who don't have an epidural. So epidurals are very widely used now. Now you'll go to some birthing centers and things like that, and there's not epidurals. They're like really wanting to do natural childbirth. So that's a different story. So be sure that you read this table. And then, so that's the first stage. So remember, you've got the latent phase, the active phase, and the transition phase in your first stage. Then you've got the second stage, which is the expulsion of the fetus, which is 30 minutes to 2 hours. That's when she's really pushing stage to delivery. And then the third stage is expulsion of the placenta. Okay, fourth stage is recovery. All right. I do want you to read that really well. You also need to know that the highest priority in the fourth stage of labor, so the fourth stage is what? Recovery period. The highest priority is hemorrhage. So you have a risk for bleeding all over the care plan. That is the part that you need to really focus on. So you have to make sure that her uterus is firm. So we massage the fundus every 15 minutes when she's, for the first hour when after she's had the baby. So we're literally feeling the top of the fundus and massaging like bread, like you're kneading bread. And we want to make sure it's good and firm. And usually it's like at the umbilicus. And if it's not firm, if it gets boggy, that can cause hemorrhage. So that's the biggest risk in that fourth stage. So we do give Pitocin right after delivery really fast to help. Remember, with Pitocin, we are contracting the uterus with synthetic drugs. So oxytocin is a hormone that's produced by your own body in your brain. And we just kind of give more of that synthetic hormone to help, contract that uterus down so that it doesn't get boggy and bleed out on us. So during labor, we have to really control the Pitocin because we don't want to overdo the Pitocin and cause all these contractions to be on top of each other. And then the baby is going to have late decelerations and lose oxygen. But once the baby is delivered and we don't have to worry about the baby anymore, we want to just open that Pitocin wide open. Like, it goes so fast, just let it drip wide open, because it's not going to hurt her now because the baby's delivered. So we want it to go really fast. Okay. The other thing is, in a known fact in maternity is that if the uterus, you go to massage the uterus, and the fundus is what we call it, which is the top of the uterus, and it's displaced, like it's over to the side, that means, what do you think that means? Yep, that means the bladder's full. The bladder's full. It's very common, especially with these people getting epidurals, because they can't feel to go to the bathroom. They can't feel to urinate. Their epidurals got them numb from the waist down pretty much. So we go ahead, and it can cause hemorrhage. So we go ahead and really good massage the uterus, but our goal would be to keep massaging it while someone else goes and gets a catheter, and we're gonna have to do an in-out cath. Because if you don't get that bladder emptied, then she's gonna continue to hemorrhage, and she can go into shock and all that stuff. So we wouldn't stop massaging the uterus. We would keep massaging the fundus and get her bladder emptied. That would be what we would need to do immediately. In your book, there is assisting with an emergency birth. We covered, that's on page 135. And then there's table 6.5. That's what we just talked about, I think. Let's see, 146. Let me look at that real quick. Make sure that's not anything important. Oh yeah, no, that is important. Table 6.5 on page 146 and 147. Does it go to 148? No. Is physiological changes in labor and nursing interventions. So read over that. It talks about what happens with the cardiovascular system, the respiratory system, the renal system, musculoskeletal, neurological, GI, endocrine, and blood. Remember, they have 50% increase in blood volume in pregnancy, increase in clotting factors. All of that is important to keep her from losing too much blood and it being a problem. So that's put into place. But at the same time, it puts her at an increased risk for pregnancy-induced hypertension and for blood clots. So that's why we always do the Homan sign after delivery, because she could get thrombophlebitis in her leg, and so we do the Homan sign to detect. And if it's a positive Homan sign, that means that when you flex the foot and you bend the knee, that she has pain in her calf, and that can mean that there could be a thrombus there. So we really do watch that. The next slide says VBAC. That's just a vaginal birth after cesarean, and that's really something that is mother's prerogative. It used to be mandated by insurance companies that women would try to do VBAC, and they've had a C-section before. Well, I think they let up on all that because it causes so many complications sometimes if you do go ahead and VBAC. And I've seen some really bad situations happen. Let's see, what do I have next? For some reason, I have a duplicate slide here, so there's another one that says 4 stages of labor. So we'll skip that. And then the next slide says intrapartum care of the woman. So typically when she's in labor, that's called intrapartum. We're doing vital signs like the tables tell us to do every 15 to 30 minutes for low risk moms. So we put an automatic blood pressure cuff on her that monitors her pulse, her blood pressure, and pulse ox. And we'll monitor that usually every 15 to 30 minutes while she's in labor. And then once she gets to complete and ready to push, then we're supposed to be doing it more frequently. So it's usually like every 5 to 15 minutes in that transition phase. So we're monitoring that, vital signs. And a lot of the fetal heart monitors have mom's heart rate on it too. So you can read it there too, that helps too. Also, we'll take her blood pressure and it'll actually print out on the strip. So that's pretty cool. We're monitoring contractions to make sure they're what we want them to be. So we're messing with the Pitocin, trying to titrate that we want our contractions to be every 2 minutes. That's what we want. And we need them to be strong enough to dilate the cervix so she can get to complete and be able to push the baby out. So we're having to really balance a lot of things. We're having to balance the contractions not being too close together, and the baby's heart rate, how it's responding to all this, how she's acting and what her behavior is, how she's responding to the whole labor process. There's so many things that you have to monitor. How the family's acting through this whole thing, because she'll have family there most of the time. So there's just so many things that you have to deal with when you're dealing with a laboring patient as a nurse. Okay? You're gonna be supportive of the family too. You might have to teach a lot, reposition, helping her breathe, providing encouragement, supporting the partner. I have several funny stories I could tell you, but I can remember one time the dad, unfortunately, was watching the epidural be put in. The needle's extremely long with an epidural. It doesn't go all the way in, but it looks terrible because it's so long. And he watched that and he literally fainted. So I'm trying to hold her for the anesthesiologist to put the epidural in and monitor the baby's heart rate. And then all of a sudden, he's in the floor and he fainted and I'm having to help him. So I learned a big lesson that no more would I let fathers stand there and watch the epidural. But that happens. They see that needle, pass smooth out. Happens a lot. Okay. So once she gets to completely dilated, so like I said, our goal, we're trying to titrate the Pitocin if we're doing induction, or if she's naturally dilating on her own, that's great. That's a better way to do it. But once she gets to fully dilated, then we as nurses have to teach her how to push, okay? So we tell her to take a deep breath and we tell her to push. This has to happen during the contractions, okay? We pull her legs back as far as we can to open up the pelvis, and we have her bear down and we count out loud. We sound like cheerleaders in there, I'm serious. And we try to teach her to not hold her breath, but to kind of be breathing out as she's pushing, because that can create problems for her respiratory wise if she does hold her breath. So we would say, take a deep breath, hold it, and kind of let yourself breathe out. We would teach that ahead of time, and we go, ready? And push down as hard as you can, like you're having a bowel movement and you're very constipated. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Blow it out, another big deep breath, and do it again. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Blow it out, get one more big deep breath. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, now take you some big deep cleansing breaths, and let's rest now. And then we have to do this every time she has a contraction. And us standing right there and doing that depends on a lot of different things. Like if you have a very good patient coach, like a husband who is right there engaged and he knows what to do and he's helping her push, you don't have to do as much of that. You just have to kind of be there in case they need you. But more times than not, you are the cheerleader. You're the one that's cheering them on. So you're the one having to tell them what to do and get them to stay focused, because they'll go out of control on you and they'll start saying, I can't do this. I can't do this. Yes, you can. Look at me. Take a deep breath. Push as hard as you can. You know, so you just have to really be on top of that with them. So that part, trust me, your abs get a little stronger too, because you're trying to bear down with them while they're pushing. There's a vaginal delivery. There's pictures of a vaginal delivery that's in your book. I have written down 153 to 154. Let me see here. Hold on one second. Yes. Very good pictures. Very good pictures. It shows the crowning. Remember, they go through an internal rotation where they rotate, and then when they come out, they go through the external rotation. That's really what you need to know on that part. But you can see the bulging of the perineum right there. See how it's bulging? So, I mean, sometimes you look at, you just can see from the way she's acting, like she's bearing down. Uh-oh, I better pull the covers back. And then all of a sudden, you see this right here. And you're like, uh-oh, I better call the doctor, stat. And as you get more experience, you learn, oh, this is a first-time mom. She's gonna take a couple hours to push the baby out. I can tell by the way it's not coming all the way down that she's gonna take some time to push. So I probably wouldn't call him and say, get right here. I would just call and let him know that she is fully dilated and we're starting to push. But something like that, yeah, you better get here quick because we're fixing to deliver. And yes, I've delivered a few on my own, and those are fun, lots of fun to do. Okay, so the next slide says nursing care during birth. Prepare for the delivery when the crowning occurs, of course. We use stirrups to help widen the pelvis, and they should be padded, of course. The beds break apart, so the bottom of the bed comes off. And then you have obviously your nursing responsibilities during that time are to continue to monitor her blood pressure, her heart rate, her oxygen level, the baby's heart rate, the contractions and what they look like, what her cervix is doing, the families, what they're doing in the room, how they're doing. Is the warmer ready? Does the warmer have oxygen ready for the baby? Does it have the radiant heater on? Do you have suction ready for the baby? If the baby needs suction, is it working? You don't want to be in a situation where these things don't work when you get the baby out. And I've had that happen before because the previous shift didn't check everything and I was thrown into something. That's not fun. You have to make sure there's a baby scale in the room because we try to weigh the baby as soon as the baby's born. You have to have baby bands ready to fill out. Like we start filling out a little bit of it and we just leave some of it blank because immediately when the baby's born, you've got to put an ID band on the ankle, on the wrist, and one on mom and one on whoever she chooses. If she doesn't choose anyone to do it, that little wristband needs to be cut into tiny pieces and thrown away because you don't want the risk of that being put into the wrong hands. Okay, let's see. So another thing is you got to set up a delivery table as the nurse. So a sterile delivery table with scissors for the doctor, a basin that he will get the placenta and put it in, sterile gloves, a red rubber catheter is usually put on there in case he needs to catheterize, and he would just like catheterize her right there with the trash can with the bed broken apart so the urine would just go in the trash can. Sometimes just getting rid of the, emptying the bladder will help the babies move down more. So we try to empty the bladder so the baby's head can move down easier. Our job in that case is to help the physician do whatever and keep all this monitoring up all at the same time. That's why we're one-on-one at this point. We have to be one-on-one. She might be needing medications. She might need her epidural adjusted, like if she's pushing, because sometimes too much of an epidural will actually make her not be able to push effectively, so we have to turn it down. Mothers are usually not very happy about that at all, but we have to do that sometimes. Remember that you can't give Stadol if you think it's going to be within an hour of the delivery. You don't want to give Stadol because the baby's going to be respiratory depressed, and then you have to give Narcan to the baby, or you might have to bag and mask the baby. When the baby does deliver, you have to do so many things. You have to make sure you massage her fundus. You have to make sure you start monitoring her vital signs every 15 minutes. You get that Pitocin wide open. Then the nursery nurse, and I've been the nursery nurse and the mommy nurse before, and it's a lot. So then you have to make sure somebody has to note the time of the delivery. Then you have to bring a blanket over for the doctor when he cuts the cord. You put the baby in the blanket, you hold on to the ankle so that you don't drop the baby, and hold it the back of the head here. You take it over to the radiant warmer, you put it on there, you dry it off really fast. I think I talked to you about that before, that neonatal resuscitation, the first thing you want to do is dry the baby off. Temperature is the number one thing that'll make it go into distress. So it loses heat real fast. So you want to get it really good and warmed up, and that'll help a lot. And then as soon as you dry it off really good, because it's going to be really wet, you remove that blanket, and then you look at the baby, and if baby's not breathing, you have to start doing bag and mask breathing for the baby. Okay. Then after that, if the baby's still not moving, you're going to check the heart rate really quick. This is all happening within like 15 seconds, y'all. Then you may have to do chest compressions, and I've had to do that before. But most of the time, it's just the breathing. Once you breathe for them, they come right start screaming and crying. That's what you want. Okay, let's see. You do an APGAR score. So that's something that the nurse does, the nursery nurse does. The babies get different points. And I think we have, let me see here. I believe we'll talk about the APGAR score. Yeah, we will in a few minutes. Examining the placenta, okay? Any abnormalities with the fetus, we look for any abnormalities. Documentation if there's infant stools or voids. And then we also have to look at how much bleeding mom is having. Then we do footprints. We usually do the footprints right there in the room. And we have to make sure we have good bonding. Okay? In the immediate postpartum period, that's the next slide. It says immediate postpartum period. We monitor for hemorrhage. Remember, that's the number one thing there. The uterine fundus is assessed for firmness. So we massage the fundus at least every 15 minutes. If it's deviated to the side, we have to empty the bladder because she's going to keep hemorrhaging. Evaluate pain. We got to look, assess her pain level. She may need pain medication. Observe the bladder function and urine output. Promote bonding. Those are things we do. Okay, so remember the expulsion of the placenta is included in the 3rd stage of labor. So they define the placenta as either Duncan or Schultz. So it depends on what's delivered first. So Duncan would be the dull side, and then shiny is the Schultz side. There's a picture in your book on page 152 that shows what the placenta looks like. So A is a Duncan delivery, and then B is a Schultz delivery. So in other words, that came out first. So it doesn't mean anything at all. It's just something that they document which one came out first. So the 4th stage of labor is 1 to 4 hours after the birth of the placenta or until the mother's stable. And then again, remember, hemorrhage is your number one focus during that stage 4. Okay. So massaging the fundus and oxytocin, we look at the color of the lochia. It should be, it's usually a bright reddish color at that point. That's called lochia rubra. And that's what we're gonna see in the hospitals, lochia rubra. It won't change colors typically until she goes home because she's gonna go home within 24 to 48 hours. An ice pack can be applied to the perineum up to 12 hours after delivery to reduce swelling. And then after that, a warm pack can be used after that first 12 hours. Sitz baths sometimes are ordered by the physician depending on if she had an episiotomy, if he cuts the episiotomy, or if she tears. And there's different degrees too. There's a 1st degree, 2nd degree, 3rd degree, and 4th degree. And I'm pretty sure we will go over that somewhere. I'm not sure where, but just know that there are different degrees. When you get a 4th degree, that means it's actually been torn or cut all the way into the rectal mucosa. That's real bad. But if your doctor had a shoulder dystocia where the shoulder would not come out, it was stuck, all you see is the baby's head out, hanging out, and it's turning bluer and bluer, and all of a sudden it's black, he has to do everything he can to get this baby out. So sometimes he'll cut a 4th degree. They'll cut her as far as he can to get more room for the baby to come out. So there's gonna be a big risk for infection with a 4th degree, laceration or an episiotomy. And we do a lot of pain medication, stuff like something called EpiFoam, which is like got lidocaine in it, and you put that EpiFoam on the pad and that helps numb the perineum. So there's things that you can do like that. Giving her daily stool softeners because you do not want her to get constipated. Okay. All right. And I talked to you about the observation of the bladder. We talked about that. And then real quickly about the newborn. The first phase is immediate care after birth to 1 hour, usually in the delivery room. This slide is called care of the newborn. The second phase is from 1 to 3 hours after birth. The third phase is from 2 to 12 hours after birth. Okay. The APGAR is just a score that we use, and it's on page 158 in your book. Let's look at that really quick here. And you give a score to the baby, but you never do this until the whole thing's over, or you've already initiated any kind of resuscitation, you've already taken care of the baby. The APGAR score is not used to do any kind of resuscitation. It's just a monitoring tool, an assessment tool, so that you can see how the baby did with delivery. Let's see, your APGAR score is actually on page 158. So you can see it has heart rate, respiratory effort, muscle tone, reflex irritability, and color. So at the bottom, you see you can do 1 minute, 5 minute, 10 minutes, and 15 minutes. Okay. The nurse evaluates each sign in the APGAR and totals the score at 1, 5, 10, and 15 minutes after birth to assess condition of the infant. A score of 4 to 7 means the infant needs gentle stimulation, such as rubbing on the back. So if you don't get an APGAR score of at least 8, 8 to 10 requires no further action. So if you get an 8 at 1 minute and then you get a 9 at 5 minutes, you don't have to keep doing APGAR scores after that. So your APGAR score would be 8, 9 in that situation. So that's perfectly fine. You don't have to keep doing that. So usually they lose points for color. That's usually what they do, because remember, they have regular fetal circulation going on where it's bypassing the lungs and the liver and all that. Remember, those shunts are being bypassed. So whenever the baby takes that big deep breath, that pressure from that big deep breath causes the shunts to close and causes the baby's lungs to open up, and the baby can actually the circulation starts changing, completely changing, and goes to regular circulation. So those circulatory changes cause there to be some color changes as the baby's first born. So it's not abnormal for the baby to be cyanotic when it's first born, like at that 1 minute period. Usually the 2 points they lose, because the maximum is 10, is usually from color. So it's normal. And we just give them a little, what we call blow by oxygen. We just like blow some oxygen right at their nose for a few minutes, and they usually just do fine after that. That's typically what they lose points for. So a 10 is, you don't usually give a baby an APGAR of 10. That's very abnormal, not hardly seen. It's usually going to be a 9, because they're still going to have acrocyanosis, where they're going to still have some cyanosis in their peripheral areas like their feet. It's normal for them to be a little bit cyanotic. So that's not anything abnormal. Now, if you have cyanosis of 8 and it continues, there's not pinking up, then you have a problem. So you just have to really watch that. So the initial care, as I told you, first thing is to maintain thermal regulation, maintaining the cardiorespiratory function, observing for urination and passage of meconium. You do a brief assessment for major anomalies, encouraging breastfeeding and bonding. The baby's usually covered in blood and amniotic fluid at birth. You always wear PPE for deliveries, because you're going to be exposed to a lot. So then on page 157, it goes over the steps of what the infant care, kind of like what we just talked about, but I'm going to go back and look at that. So it goes over the steps of what you're doing. So right under on page 157, it talks the heading that says maintaining thermoregulation. If you go underneath that, there's some bulleted items. Drying the infant with a towel to prevent heat loss caused by evaporation and amniotic fluid on the skin. The body and head should be gently dried with a warm towel. Okay, so you're under a radiant heater, so that's what you want. The second bullet said placing the infant under the radiant warmer. Then you put a skin probe on, and that helps maintain the temperature you want them at. There's a picture of a radiant warmer on page 157 at the top. Placing a hat on the infant's head. That's vitally important, that you put a hat on the infant's head before you take it off that warmer and wrap it up in a blanket, so that when you give it to mom, that's what we want to do to promote bonding. The head is the quickest place the baby can lose that heat, so you want to have that hat put on that head. And then the warm blankets. So let's see. Usually just some mild stimulation, like kind of rubbing the soles of the feet, will be all it takes for a baby to start crying. You know, you see old movies where the doctor spanks the baby on the butt. They don't really do that. They may have, I think they did used to do that. They don't do that now. They just do some stimulation. But if you stimulate the baby 2 times and it doesn't start breathing on its own, you start going to bag and mask respiration. Remember, this is after you've done the drying off, because that's the first thing, is the thermal regulation. Okay. Just quickly to let you know, there's a slide that says cord blood banking. That's where I'm at now. There's private and public cord blood banks. That's similar to bone marrow. It can be used to replace diseased cells or treat malignant or genetic diseases in children. So there's accreditations by the American Association of Blood Banks. Private blood banks are used for family and have a maintenance fee. They can't be used for the infant because they could contain malignant cells in them. It requires a consent form. It has to be transported within 48 hours. The registry provides parents with containers for storage for the cord blood until it's picked up by the registry. Each unit of cord blood must contain 40 milliliters for use in children and 70 milliliters for use in adults. The cord blood has hematopoietic stem cells, so it's better than bone marrow or peripheral stem cells. Can treat things like genetic disorders, immune disorders, or neurological disorders. So that's something that they can do. And I believe they do pay them for banking that cord blood. The next slide says infant signs of respiratory distress. So just if you do see continued distress, like the baby doesn't pink up right away and doesn't breathe like it's supposed to, it continues, you're going to see persistent cyanosis. So that's going to be the central cyanosis. Remember, just with the hands and feet, it's called acrocyanosis. You'll have what's called grunting respiration, so that you'll hear grunting noises when the baby's breathing. Flaring of the nostrils, nasal flaring. Retractions means the chest is retracting. You can see the baby working really hard to breathe, so you'll see that chest retracting. So we call that retractions. The baby's having retractions. We all know what this language means in labor and delivery. So if we say, oh, the baby's having flaring and retractions, then we know what that means, that there's distress. Tachypnea greater than 60. So sometimes if they're in distress, they'll breathe real fast. And then they'll have the cyanosis, and they'll have the grunting and the flaring and the retractions also. And then sometimes their heart rate will get really fast. They'll get tachycardic greater than 160, or they'll have sustained bradycardia, which would be less than 110. Okay. Then let's see, the next slide says microbiomes and nursing care. So nursing care during labor and delivery. Okay. Microbiota are a community of microorganisms, both pathogenic and non-pathogenic in every person. Microbiomes contain the genetic material of organisms that have bacteria, fungi, and several cell organisms. Mothers transfer these microbiomes to the infant during birth by mouth or vaginal contact. They're very important for the infant future health, not to promote this transfer by promoting vaginal deliveries, limiting vaginal exams. This is some research they've done. Only use antibiotics if they have to, because that can actually interfere with microbiomes. C-section babies don't get these microbiomes, and they could be at risk for health problems later in life. They know that. Skin-to-skin contact promotes transfer, and breastfeeding does. Use plain water to maintain microbial colonization. And a good diet is important with this as well. So that's basically just telling you that microbiomes are good bacteria that need to be passed from mom to baby. So it's a good thing, okay? So that's the last slide for this unit. So I'm not gonna keep recording this, but I'm gonna try, I don't know how good it's gonna come out, but I'm gonna try to see if I can show you the vaginal delivery. So bear with me here. I'm gonna take this phone off of this stand I have it on, and I'm going to try to see if I can show you on my computer screen see if I can show you. Hold on 1 second here. We'll see what we can do. If I could show you the vaginal delivery, I would be very happy. I want to show you that. Let me scroll down to the vaginal delivery and see if I can click on that, and hopefully you can see my computer screen good, and hopefully it'll work. Let's see here. Let me see if I can get a good picture of it. Trying to load here. Okay. All right. Let's see if I can make this bigger here. Here we go. Now, I hope you can see this okay. That's just the baby's head that's come out. Look how big the head is. It's huge, right? Okay, you're gonna see that external rotation here now. Usually you'll see it. You see the fluid coming out? There's amniotic fluid there. Lots of amniotic fluid. Big baby. See how it rotated its head to the side? It was straight down, and then it just, after it comes out, it just rotates to the side. There you go. Now, this is the time we're telling her to push. We're like 1, 2, 3, 4, 5, 6. You know, have her bear down for us there. Lots of fluid. This is a big baby. If I had to guess, it looks like our first one. So this is where they could get stuck. The head comes, and then that's called a shoulder dystocia. That's where things get really scary. There it is. Let's see all that gush of fluid that came out right there at the end. That was a lot. Okay, as you can see, the cord is still on there, so the placenta's still in. See how they're drying the baby off? They're making sure they dry the baby off. So thermal regulation, even though they didn't take it to the warmer, they don't always take it straight to the warmer. Sometimes they'll just dry the baby off and want to just put it right on mom's chest. They're skin to skin right there. That's called kangaroo care. Skin to skin contact. Oh, look at that baby, so cute. This is where they say she forgets all the pain she just went through. And see, the baby's even trying to root. Rooting is where it kind of starts looking for the nipple to suck on. The baby's rooting there. It's so cute. They're still drying the baby off. But the amount of heat, see, she's putting the hat on. The amount of heat that's radiated from mom to baby right there is amazing. How it can just totally regulate the temperature. So that's, I hope that you saw that okay. Okay, I'm gonna end this video lecture now so I can start on the next one. The next 2 chapters are not gonna be near as long. So I hope that this is helpful, and we will be seeing you shortly.